It will be a clinical case presentation from Rajagiri Hospital. The topic is unusual, presentation of a usual FUO. The speaker is Dr. Salini Baby John, and the moderator is Dr. George Koruth, who is a senior consultant physician at Rajagiri Hospital. Now, may I request Dr. George to please come out to the dais, and also Dr. Salini for case presentation.
Good evening, everybody. Physicians today, I think, have only fevers in their hands. Everything else has been taken away from them. And still, the most challenging thing in medicine still is a prolonged fever. So today, Dr. Salini is going to present a case of a prolonged fever of more than 3 weeks duration, meeting most of the classic guidelines regarding a prolonged fever. I hand it over to Dr. Salini, who is consultant in medicine at Rajagiri Hospital. Thank you.
Thank you, Koruth sir. Good evening, respected seniors and dear colleagues. I, Dr. Salini, from Department of General Medicine. We present a case of unusual presentation of a usual fever. We had a 42-year-old female, a village officer by profession, presented to our OPD with 26 days of fever, which was mainly nocturnal, with associated features of abdominal distension, chills and headache at the time of fever. She had generalized weakness, which was gradually progressive in nature. She has taken azithromycin, cefixime and levofloxacin, each of 7 days from outside nearby hospitals. She had no other past relevant medical histories. In social history, she was from an upper middle class family, educated female. She neither gives any history of travel outside Kerala for last 8 months. No history of any addictions nor any substance abuses. Her diet was normal, no high-risk sexual practices, no pets at home, nor any close encounter with animals. In general examination, she was conscious-oriented. Even though she had fever for 26 days, she was well-built and nourished, and she was not looking sick. She was febrile, 102.2 degree Fahrenheit. Blood pressure was normal. She had tachycardia. In systemic examination, per abdomen, she had mild tenderness at left hypochondrium with mild hepatosplenomegaly. From the prior history and physical examination, we could conclude that we had a middle-aged female with high-grade temperature, which was intermittent with associated chills and headache of 26 days of duration, with abdominal distension with gradually progressive tiredness. In physical examination, she had high-grade temperature with mild hepatosplenomegaly. So, any suggestions, any differential diagnosis for fever with hepatosplenomegaly from?
As all of you will agree, this is what we classically see in medicine today. More than 3 weeks of fever. History is usually unrewarding. History of multiple antibiotics. And clinical examination, very few features that will help us reach a diagnosis.
BCG scar was there, sir. No, sir. Yes, sir, we had.
Dr. Salini will go ahead with the differential diagnosis that we thought at this point of time.
As any other fever of unknown origin, we divided these differential diagnosis into infectious causes, neoplastic causes, rheumatologic and other miscellaneous causes. Under infectious causes, we thought about enteric fever, disseminated tuberculosis, infective endocarditis, brucellosis. Even though the duration is not very classical, we even thought about Weil's disease, scrub typhus also, acute malaria, acute kala ulcer, infectious mononucleosis, HIV, viral hepatitis B and C, cytomegalovirus, histoplasmosis, disseminated cryptococcosis, teloromycosis, malignancies like acute leukemia, lymphoma, and other causes like hemolytic anemia, SLE, and adult onset Still's disease. Shall I go to the laboratory investigations? So in routine investigations, we got raised ESR and CRP was raised, and alkaline phosphatase was 342 and gamma GT was 327. Any other investigations you?
Chest X-ray.
Chest X-ray was normal, sir. Can I go to the imaging, sir?
Ultrasound abdomen.
It was negative, sir. So procalcitonin was, we haven't done, sir. Procal we haven't done. CRP was raised, sir. CRP was 74.3, sir. Imaging, we had USG abdomen showed borderline hepatosplenomegaly, and CT abdomen and chest showed microabscesses.
Microabscesses in the liver and spleen.
Spleen and liver.
Amyloidosis is a possibility. I agree with you.
Our DDs,
Anything else? Anything else? Beg your pardon? Thought of bacterial endocarditis also.
HIV was negative, sir.
HIV was negative. Staphylococcal abscesses. Patient would have been very sick.
Is
Okay.
that possible, sir? Possible, sir.
Possible. Continue.
Our blood culture group Brucella meltensis. Brucella antigen was positive. We had negative malaria, EBV was negative, pulmonal was negative, dengue lepto was negative, HBsAg, HCV, Vidal, Wheel Felix, ANA, IAFA was negative, echo and TE was negative, except mild MR and TR. Can I? So we'll nail the diagnosis brucellosis. So as we all know, brucellosis, I know you all will be very familiar with brucellosis. It is otherwise known as Mediterranean fever, Malta fever, or undulant fever. It is caused by genus Brucella group of bacteria. It is a non-motile, small aerobic bacteria, gram-negative coccobacilli actually. It is a zoonotic disease with an incubation period of 2 to 4 weeks. Spread is usually from animal to human. Human to human is also possible in mother milk and through placenta, but it is very rare. Diagnosis is mainly by the gold standard of diagnosis is blood culture. We can also take it to the serological investigations also can be positive, and it can be taken as only probable brucella. If it's culture positive only, we can conclude it as 100% brucella. And about complications, it's a systemic disease. Usually 70% affects osteoarticular disease, and genitourinary also 10%, dermatological manifestations in 10%, serious involvement in 3%, pulmonological involvement in 2%, CNS in 2%, and intra-abdominal symptoms like abscesses are very rare, less than 0.5%. It can be fatal in less than 5% and low risk of relapse and chronicity. And various regimens, in non-pregnant adults, we can have various regimens like doxycycline with streptomycin, doxycycline with gentamicin, and doxycycline with rifampicin. In pregnant adults, if it is more than or equal to 36 weeks, rifampicin alone is the drug of choice, and after delivery, a combination drug as non-pregnant adult can be taken. So we opted for a doxycycline with gentamicin combination because study says that it reduces the chance of relapse. Take home message, as I told earlier, it has a very long, it's a very slow growing bacteria. So when you have a suspicion of brucella, kindly let your lab know that you are suspecting brucella, and they can incubate the blood culture for a longer period, more than 4 days. And it may take up to 10 days for brucella to grow in blood cultures. So that is the commonest cause. We don't get blood culture positive nowadays for brucella.
We presented this case with two intentions in mind. The first thing was the use of blood cultures in the diagnosis of bacterial infections. Brucella is a fairly difficult organism to grow. All 3 blood cultures grew brucella, even though this patient had been on 3 antibiotics prior to this. The fact that we were able to treat her with full confidence and not finally start her on empirical ATT was because of blood cultures. The second take-home message that we thought was important was the use of antibiotics without a settled source of infection. Empirical antibiotics always complicate treatment, and that is one of the causes of a prolonged fever. So these are the 2 take-home messages that we thought was important with this one simple case of brucellosis. Thank you. If there are no questions, we will conclude.
How did this patient get brucellosis? Seems like contaminated milk and all that, right?
So actually we tried, we poked her out after this. Only thing is, she was telling that after this COVID time now, so she started getting milk from local vendors. She just, before getting boiled, she just used it for coffee with brew, instant brew. That was the only history. She never had any.
So she had non-pasteurized milk.
Non-pasteurized milk.
Second thing, the giving levofloxacin empirically should be stopped because it can camouflage a lot of diagnosis.
So one of the reasons why we said unless we have an established source of infection, antibiotics should not be used.
Regarding the spread of brucellosis in this area, especially Aluva and Chunagamvely, people take milk, make curd without boiling the milk, because we used to get cases, and I used to go into the wave and how they have got it. Then I could understand that most of them were using the milk which was not boiled for making curd. Second is our females who are handle the meat, they don't use gloves or anything. They may have cuts on their fingers, they chop the meat with that cut fingers, and directly the bacteria gets in.
Yes.
So these are the 2 things which I have thought of as the possibility, and whenever you get a case of a prolonged fever in that area, you have to ask for a contact with cows, goat, other types of animals. Thank you.
Thank you very much for a patient hearing.
May I request Dr. George Koruth sir to present a moment of appreciation to Dr. Salini. May I request Dr. Sanyardal sir? Okay. I request Dr. Sanyardal sir to present the moment of appreciation to our chairperson, Dr. George Koruth.
Hello, yeah. We thank the Rajagiri Hospital team for bringing out such a wonderful case, particularly physician-oriented case, and PUO is probably the most naughty diagnosis in clinical medicine. So, now I had to make a few announcements. The first thing is that next month, that's for the month of March, we will have, instead of the usual meet on Friday, we are scheduling it for Saturday. That will be 26th of March. The reason being, it will be a talk, a symposium on diabetes titled API Kochi and Diabetes in Indian scenario, Indian reality conclave. Yeah, the four eminent speakers will be deliberating on the subject, and the talk will be sponsored by Novo Nordisk. So we decided to have it on Saturday because after Friday, if you have to really enjoy your drinks and food, it will become rather too difficult. So we postponed to Saturday that you don't have the pressure to come for work the next morning. A final announcement is the present office bearers team is ending in April. We took over on 8th of April last year. So we are announcing the elections to be held for the new office bearers. Dr. Madhu Kumar has kindly agreed to be the returning officer. So is Dr. Madhu here? Thank you, Dr. Madhu. So I request the members to submit their nominations for chairperson, the vice chairperson, treasurer in the month of March to Dr. Madhu. Now we are reaching towards the end of today's meet. I request Dr. Sumesh to kindly pay the vote of thanks.
On behalf of the organizing team, it's my privilege to propose the vote of thanks. A big thank you to Dr. Praveen Srikumar for not only sparing his valuable time, but also for enlightening us with his commendable talk on atrial fibrillation. Thank you, sir. Grateful to our respected member, Dr. Sujit Vasudevan, sir, for chairing the session in his usual impeccable style, in spite of his busy schedule. I'd like to express our sincere thanks to Dr. Salini Baby John for presenting an eye-opener of a case. It will definitely open our mind's eye to various scenarios that we face daily. Thank you, madam. We wish to express our gratitude to Dr. George Koruth for moderating the session and discussing the various intricacies of the case. We are very grateful to Astor Medicity for again coming forward and sponsoring today's CME in association with Meditronics. Thanks to Aaron Moses and his team for a glitch-free CME. Thanks to Nila for organizing this scrumptious feat later. Word of appreciation to Sandeep, Jiju and the IMA team in helping us to organize today's CME. And most importantly, a big thank you to all you respected delegates for accepting our invitation and coming to the CME and encouraging the morale of our speakers by your august presence and enthusiasm. Thank you all once again and have a good night. May I request everybody to stand up for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे